It's so good to be with all of you today. My background is pharmacy, and it's good to be with a group of people who think it's something other than the drugs. We're always talking about the drugs. It's been such a pleasure working with Nancy over the past year, and I know she had this idea early on, and here we are today on this day we've all anticipated for so long. It's just wonderful to see so many people here. The presentation this morning was just terrific, and I can see the energy here in the room. I'm especially happy to introduce Dr. Terry Fulmer, whom I worked with for several years when she served here as the Dean of the Bouvet College of Health Sciences. Last year, she left us, sort of, not completely. Her heart is still here partly, to become the president of the John A. Hartford Foundation in New York City. This is an organization which many of you probably know about that's dedicated to improving the care of older adults, and Terry's work has been in gerontology, and she's distinguished herself in so many ways in that area. Before she was at Northeastern, she was the founding dean of the College of Nursing at New York University and has had previous appointments at Columbia University, Yale University, and Boston College, her alma mater. Terry, as many of you probably know, is an internationally recognized authority on the acute care of elderly and specifically abuse and neglect of the elderly. She's a fellow of the American Academy of Nursing, the Gerontological Society of America, the New York Academy of Medicine, and a distinguished professor in the National Academies of Practice. With significant federal, foundation, and other forms of grant funding, she's been a prolific scholar and mentor, contributing extensively to the literature and her students, and serving regularly as a speaker at professional, scientific, and health policy forums. Terry received a Bachelor of Science in Nursing degree from Skidmore College and her MS and PhD degrees right here in Boston at Boston College. It is my honor to welcome Terry back to Northeastern University to address you today.
Thank you so much, Jack and Nancy, and what a privilege and pleasure to join you this afternoon and to be a very small part of this wonderful, wonderful Nurse Innovation Entrepreneurship meeting. I heard about the morning. It sounded just riveting to me, so exciting. And aren't we, as nurses, aren't we the innovators? Isn't it the nurse who does every workaround known to mankind? Right? Is that not innovation? All you have to do is go to any practice site and you will see innovation and entrepreneurship at its finest. Now, when you take that to the next level, to the university, in this amazing university, which I had the privilege to work at and just love Northeastern, when you take it to this level, all of a sudden you're in a whole new plane, where you're thinking about the ways that you will create the science and the practice protocols that will fundamentally change the well-being of the people we take care of every day. In my case, geriatric patients, and thinking about the age wave, when at the John A. Hartford Foundation, we have one mission, and that is to improve care of older adults. So with 10,000 people turning 65 every day, that's something that wakes me up every morning. And when we think about the fact that it's really not about those people at all, is it? It's about our 85-year-olds, our 95-year-olds. That is the innovation we need to say. And so for me this afternoon, just to be with you and to be able to see the faces of the people who make it happen every day is so meaningful to me. And Nancy, what a gem of a dean we have. Can we all clap for Nancy hand in hand? Nancy joined this university from the University of Pennsylvania. I know you saw her distinguished bio, but she had a vision. And as I interviewed her, and I had the privilege of taking credit for hiring her, I did. So as we thought about what she would bring, she had one thing in mind. We will be the school of nursing that is known for entrepreneurship, and we will be entrepreneurial. We know what enterprise looks like, and I think she's proven that today. So Jack, your warm words mean the world to me from my Northeastern family. Nancy, I watch your work every day, and it's an honor and privilege to be a part of you. Nurses and nursing friends, thank you for letting me be here today. Thank you so much.
So I had the distinct pleasure of having dinner with Patty a few weeks ago, and I learned about her because she is an extraordinary innovator. She is an assistant professor of medicine at Harvard Medical School. I hope to bring her to Northeastern School of Nursing. She's a senior nurse scientist, program director of nursing research and Center for Nursing Excellence at the Brigham and Women's Hospital Department of Medicine and General Medicine. She's going to be talking to us about utilizing IT to improve patient engagement and team communications. She's an extraordinary nurse scientist. Her program of research relates to the use of technology to promote communication, care coordination, and patient safety. Dr. Dykes and her team have been funded by the Robert Wood Johnson Foundation to develop and test a web-based fall prevention toolkit. The toolkit was found to significantly reduce falls in acute care hospitals, and the results of their studies were their study was published in the Journal of the American Medical Association, which is no minor feat. She is currently the Partners Healthcare Site Principal Investigator for a PCORI NIA-funded fall prevention clinical trial. She's the author of 2 books and over 70 peer-reviewed publications and has presented her work related to nursing informatics, clinical documentation, and patient safety, both nationally and internationally. She's a member of the U.S. National Institutes of Health Biomedical Computing and Health Informatics Study Section, Center for Scientific Review, and an elected fellow of the American Academy of Nursing and the American College of Medical Informatics. Please welcome Patty Dykes.
Thank you so much, Nancy. Thank all of you for coming here today, and I'm really thrilled to be included. I'm grateful to the planning committee and all of the nurses who are in this room today who are interested and dedicated to learning about innovation and taking the first steps to learning about how they can bring the innovations that they have or the ideas that they have to fruition. And this summit and the hackathon over the next couple of days will give you the skill set that you need to do that, because you already have the ideas, and then it's going to be very operational and get you moving. So I'm really happy to be part of this. So today I'm going to be talking about using health IT to improve patient engagement and team communication. And this is a project that was funded by the Gordon and Betty Moore Foundation. But I'll start by first talking about the current state of healthcare team communication. This morning in one of the breakout sessions, we were talking about, what are the steps to identifying innovations? And the first is identifying a need. And any nurse who's worked in acute care, I worked in acute care for a long time, knows that sometimes there are communication problems. And that really was, really spurred on a lot of the different innovations that our team has worked on. I'm also going to be talking about patient engagement and why we believe that this is so important to be a component of any innovation that we're thinking about. How are we involving the patient? How is this important to the patient? I'll talk about the Prospect Project and hopefully help you understand how we're able to integrate those aspects of communication and patient engagement to make this an intervention that was pretty successful in acute care setting. And I'll talk about some of the lessons learned. So all of us go into nursing and healthcare because we want to help others. We want to do the right thing for patients. And yet we know that medical harms are the 3rd leading cause of death in the United States behind heart disease and cancer. We also know that ineffective communication is a very frequent root cause of medical harm. Any of you who have worked in healthcare know that there are many communication challenges, and this is particularly true in hospital settings where we have multiple handoffs. Sometimes a patient over a week's length of stay might have 30 or 40 providers that care for them, professional, paraprofessional. There are many different types of communication methods that people use. Some people communicate using pager or telephone or through the EHR using email. And so the result of that is sometimes we have parallel siloed communications, and very often the whole team is not on the same page about what the patient's primary goals are and you know, really what we're trying to do with the patient. There are also inconsistent beliefs across the care team around what the patient and family role is on the care team. A few years ago, we did some baseline data collection just to get an idea of how we were doing with care plan concordance. So specifically, we wanted to know how often is the nurse, the responding physician, and the patient all on the same page about the patient's primary goal for hospitalization? And what we found was it's about a quarter of the time, 25%, where all three players were on the same page. So, you know, even in an excellent hospital, Brigham and Women's Hospital, where I work, we still have issues with communication that are real. The IOM has defined patient-centered care as providing care that's respectful of and responsive to individual patients' preferences, needs, and values, ensuring that the patient value guides all clinical decisions. And I think as nurses, we really try to do that consistently. But because of the workflows, because of the multiple handoffs and all these other challenges we've talked about, it's not always easy to keep the patient at the center. One precondition for patient-centered care is patient engagement. And so there's been a lot of research. Judith Hibbard out of Oregon has said, you know, to have patient engagement, you need patient activation. So patients have to be willing to really participate and be active, but they also need the tools, the interventions, and strategies for engaging in their health care. She also said that there's 4 stages of patient activation, and the first stage is believing that the patient role is important. And this really has to exist within the patient, but also within the team members, because through our body language and through our behavior with the patient, we sort of communicate how important we believe it is that they participate. A second stage is having the confidence and knowledge to take action. So a patient might believe that it's really important for them to be involved in their care, but if they don't have the information they need, if they're not confident enough to speak up when they feel like they should, then we will not have activation. The third stage is taking action to maintain and improve one's health, so being able to actually do it, and then staying the course even under stress. So even when there are members of the care team that don't believe that the patient should be activated, even then the patient can say, yes, this is really important and I'm going to do it. There is some research that suggests that activated and engaged patients have better outcomes. They are more likely to engage in their preventative checkups and screenings and immunizations. They're more likely to engage in healthy behaviors, such as eating a healthy diet and doing exercise regularly. And they're more likely to avoid health-damaging behaviors, such as smoking. So there is also research that suggests that patients who are activated, their costs are about 20% lower than people who are at the lowest level of activation. So there is a continuum of engagement. So it's not that, you know, do we engage our patients or do we not engage our patients? And I think that nurses tend to engage patients, and in healthcare we really try to. But I think looking at engagement as a continuum is helpful, because I think at the low end there's consultation. So I think all of us would say yes. You know, we do consult with our patients. We might provide them educational materials so that they can learn about their condition. But we need to go a step further. The next stage is involvement. So this is, not only are we providing them with information, but we're also inquiring about their preferences, and we're using that knowledge of their preferences in decisions that are made with them. And then the third is partnership and shared leadership. So at this end of the continuum, the patient and the care team are partners. Patients have access to the same information that the care team has, but in a level of health literacy that they can actually use to make informed decisions. And when decisions are made, they're evidence-based, and they include the patient's preferences. So, I think all of us believe, yes, it would be a good idea to engage with patients, but, when you try to operationalize this, and I've tried to operationalize this my whole career, and I hear a lot of excuses. Yes, this is a great idea. We want to engage the patients, but ours are too sick, or ours have poor health literacy, so they wouldn't understand this kind of thing, or they're not motivated, or they don't have the right support, or we don't have enough resources to do this. And so it doesn't matter what environment or what hospital or really where you're working, there are always limitations, and there's always reasons why people will tell you that you can't engage with patients or you can't do it well here. But, we need to step out of that and start to develop tools and find ways to provide information to patients and tools to patients so that they can be activated and engaged. And that's really what we tried to do with the Prospect project. So Prospect stands for Promoting Respect and Ongoing Safety Through Engagement, Communication, and Technology. Prospect was funded by the Gordon and Betty Moore Foundation. Our goal was to transform the intensive care and oncology environments through implementation of a patient-centered intervention. And our focus was on both patients and their care partners. Prospect is part of the Libretto Consortium, so there are 4 other hospitals around the U.S. that are part of this consortium. The BI is one, Johns Hopkins, and also UCSF. So with Prospect, we had 3 specific aims. We wanted to minimize preventable harms. We also wanted to optimize the overall patient experience for both patients and their care partners. And we really were focusing on engaging patients and promoting dignity and respect as part of that experience. And we really believed or hypothesized that by doing all this, we would reduce unnecessary utilization and cost. So we were first funded to do this about 2 years ago, and we started by doing some preliminary work. But what we wanted to do was we had a portal, a patient portal, an inpatient portal that focused on the patient's plan of care and involving patients in identifying their goals of care, giving them more information about their problems and how the healthcare team was working to resolve those problems, but also giving them the core set of information that they needed to participate and engage throughout their hospital stay. But from doing preliminary work of workflow observations and interviews and focus groups, we learned very quickly that just implementing the portal wasn't going to work because there wasn't enough of the clinician documentation that was online where it could be shared with the patient. And the clinicians were really quite clear that they weren't doing double documenting. They were very happy to engage with patients, but we had to make it easy for them to do that. And so that was really our charge. And so over the course of about 9 months, we worked with the clinical teams, with the patients and family, and we developed a multifaceted intervention. It was 2 pieces. One part was the patient satisfaction model, and that was a communication and engagement model where we had the clinicians working with the patients in real time in admission throughout the hospital stay and on discharge about the patient's needs, their concerns, and their expectations. They'd be asked about that every shift, and when patients had issues, we try to address them in real time. We also had developed what we called the web-based patient-centered toolkit. And so instead of this just being a patient portal, we expanded it to include a suite of tools for both patients and providers. And I'm going to show you what some of the tools that were included in that suite. So one component was the microblog. So we talked about issues with communication and trying to get everybody on the same page. So we thought, well, wouldn't it be great if we had this microblog that patients could ask questions of the clinical team, and the clinical team could blog back and forth and figure it out, and then maybe message back to the patients. So, you know, for some clinicians, they thought this was a great idea. Other clinicians thought we were crazy. They didn't want patients microblogging them. But, you know, through working with the team, we found out some, you know, acceptable workflows. So, for example, there had to be separate patient and provider threads. So the providers wanted to make sure that if a patient asked them a question and they wanted to, you know, they wanted to consult to the care team, they didn't want that information automatically going back to the patient. And I'll never forget one physician saying, you know, when I go to a fine restaurant, I want to see my beautiful dinner after it's prepared. I don't want to see what happens in the kitchen. And that's how they had described, you know, maybe what goes on sometimes with the team. And, you know, it makes perfect sense because, remember, we're in the ICU and we're also in oncology. And with both of these groups of patients, particularly in the ICU, the plan's changing all the time. You know, the patient comes in, they're very critically ill. You may not know what the problem is. You're working on many different critical issues, and patients are not, or providers are not necessarily comfortable with the patient knowing and the family how much uncertainty there is. It's, you know, that's just the way it is. But the microblog did help with, you know, the workflow was instead of using like email and pagers, just use the microblog. So instead of having just two-way communication, we have the whole team has access to the communication. So if I'm off for 3 days and I come on, I can look up the conversation stream about this patient and get caught up to speed. We also designed a multidisciplinary plan of care platform. So at this time, the whole team was documenting on paper at the Brigham for their plan of care. And what we really wanted to do was have it be a patient plan of care. We wanted the patients and the team to be on the same page about what the goals were and what we were doing to try to resolve problems and to meet the goals. And so what we did is we moved the paper plan of care electronic. And we divided it up so the top section was any information that was going to be, that was documented by the patient. So I'll show you some of the patient tools in a few minutes. So if patient documented what their concerns were, what their goals were, what they thought their issues or problems were, that could be viewed right at the top of the multidisciplinary plan of care. At the middle section, that's where they could add new problems to the patient plan. And when they added problems, they could these would automatically be viewable by the patient. They could also select goals. Again, these would be viewable to the patient. We were pulling in data from a physician order entry or provider order entry, and then the providers could put that on the patient's schedule so they could see in their portal, you know, what was happening that day. This is a screenshot of the nursing plan of care worksheet. So for, you know, like the multidisciplinary plan of care, which was used during rounds, very often the nurses also had a separate worksheet. You know, before this went electronic, they did this on paper. They would, you know, after rounds, identify new problems to put on the plan, and they would use that, you know, to plan their care, but also to educate the patients. So when we designed this electronically, initially our thought was, well, you know, we'll make it so that any problems you add to the plan will automatically go to the patients. Well, the nurses didn't want that. They said, no, we don't want we don't want the patients to see all their problems. We want to be able to decide which ones they see and which ones they don't. And so to operationalize this and get this out, we gave them the capability. So you can see there's some locks there, right? Red locks mean that the nurse does not want to share this with the patient. Green means that they want to share it with the patient. So anything that's shared with the patient goes to the patient's portal, and there's going to be a Medline Plus info button so the patient can get information about it. And, you know, a lot of the nurses' concerns were legitimate. So, for example, think about an ICU patient. They have a lot of problems. And so many of them were concerned that if we shared all of that with the patient, that they would be overwhelmed, and the family, and they wouldn't be able to, you know, wouldn't motivate them or engage them or activate them. It might make them feel burdened. So that was really the rationale. We also developed a safety checklist tool. So before we had done this project, the medical intensive care unit, they were using a paper checklist. And the physicians believed that their contribution, a lot of their contribution to the plan of care came from this checklist, and that we should work with them on making this electronic so that their contribution could also be displayed in the patient portal. And so what the checklist did is it pulled in data from the EHR to populate the bundles that they're looking at anyway. So, for example, the vent bundle, you know, the angle, the head of the bed, the spontaneous awakening trial. And where it was improved upon from the paper checklist was that on the paper checklist, the physicians thought that it was a little bit too easy to skip over some of the items. And so the rule was, with the electronic checklist, it was used during rounds for every single patient. If an item was not indicated for a patient, it was required that the reason was documented. Oh, somebody's phone and it's ringing. So they had to document the reason why something was contraindicated. And so what we observed was that Foley's that maybe would have stayed in were then taken out, because if we weren't going to take them out, we had to say why they had to stay in. Same with the central lines. This is the home page of the patient portal. So here you can see when they log in, they land on their plan of care page. And here's where they document what their overall goal is for the hospitalization. That's going to be viewable on the multidisciplinary plan of care. They can also document their daily goal. And then the care team goals that are documented by the care team are viewable here as well. On this page, we also allowed patients to tell us preferences about their care. From the Problems tab, so this is where they would view the problems that were moved over to the plan of care, and they could also document their concerns. So patients, you know, the language that you use what patients use about their problems is different than maybe the language we would use. So we call them problems, patients call them concerns. So they were able to document their concerns, but for the problems that were in their plan of care, you know, they could view those and also click on them and get we linked them up to Medline Plus so that they could get the content right from Medline Plus, and then the nurses and the team would also have that for education. From any page in the portal, the patient could message their care team. So if, you know, this was an area where the team was very concerned about messaging, and we really had to work with the team and the patients around scoping. And so what we did was, you know, when patients were enrolled in the, you know, given the portal and enrolled in the study, we told them, you know, this portal is for you. It's to help you be more involved in your plan of care and your treatment while you're in the hospital. If you have any concerns about your plan, please let us know. And we will get back to you sometime in the next 24 hours, either through the portal or in person. So this way, you know, there's some discussions that really shouldn't be happening via messaging portal, and there's other, you know, some things that are easier to do if you come to the bedside. But whatever the patient documented was viewable in the multidisciplinary plan of care, and that was in part of rounds. There was an item on the checklist to check the patient's contribution over the last 24 hours to see if we needed a follow-up plan around addressing those issues. The patient could also see who the members were of their care team. So this, again, pulling in from one of the services we have at Partners. Here are the risk icons. So, based on what's documented in the plan of care and what is checked off on the safety checklist during rounds, patients would see icons about the adverse events that they were at risk for while they were in the hospital. And so, again, they could click on these and find more information. We were hoping that this would also spur conversations between them and their care team. They also had access to their medication lists, and we encouraged them, when your nurses come in to pass medications, open your medication list. One of the main reasons why patients are readmitted to hospitals is because they don't know their medications, right, or they have trouble with adherence. And so starting that teaching right when the patient first comes in, I think, is really important. And again, providing the Medline Plus, this is all content that's in the public domain. It's beautifully written and formatted. We made use of that. And so that was the intervention, and we conducted a interrupted time series design. It was really a pre-post. Our pre-implementation phase was from July of 2013 through June of 2014. Then in mid-June until the end of June, we implemented our prospect intervention. That means we trained, everyone on all the units on the intervention and how to use it. And then post-implementation, we collected data, and I'll show you some of the outcomes that we looked at. So our primary outcome was aggregate preventable harms. So we know that the harms in the ICU, one is too many, and they're not frequent enough that any one in particular we thought would be significant. But we hope that, through these new tools and engaging the patients and families more, that we could reduce preventable harms in the aggregate. We also were looking at dignity, respect, experience, and satisfaction. So, HCAHPS is the most common measure of patient experience. We also looked at the FSICU, which is a family survey of experience. We also looked at care plan concordance. I showed you what our baseline was. 25% of the time we're on the same page with the patient. And then healthcare utilization, and we use length of stay and 30-day readmission as proxies. Our statistical methods, we used weighted propensity scores, and we accounted for a number of differences across the patients that are listed here. And so for the period of the intervention, we had in the medical intensive care, before the intervention, we had 1,030 and post 1,075, and in oncology, a little over 700 in both groups. And the users pre and post were very similar. And so what did we find? So in the ICU, we found that the preventable harm rate, so that's aggregate preventable harms per 1,000 patient days, was reduced by about 1/3. We found that the overall satisfaction rating, this is a patient using the HCAHPS, increased by over 20 points. We found that the care partner satisfaction increased very significantly. We found that the global concordance, although it was significant, it's not impressive. We went from 27% to 34%. And then we found that resource utilization really remained unchanged. So that's the ICU. In oncology, we found that while we saw the trends all going in the right direction, nothing was significant. It was a very different picture than what we saw in the ICU. Now, the difference is in the intervention, where that in the oncology units, they didn't have the checklist, and they didn't have regionalized care. So there was teams going in all different places in the hospital and also over to Dana-Farber. And then from a qualitative perspective, these are some of the quotes from our patients. They really loved the intervention. They thought it was a great idea. They loved seeing their care team. You know, some of the clinicians would hide their picture in the system, so that meant that it would come up as a blank for the patient, and the patients would say to them, "Why can't I see your picture in the portal?" But they really felt like, you know, we were trying to involve them in their care, and they really seemed to enjoy it. So we learned a lot of lessons through this project. The first is that, you know, the clinical outcomes and the patient care partner experience, it really improved markedly in the medical intensive care unit, but not really in oncology. This taught us some important lessons about, you know, sort of how care is structured and, you know, the importance of looking at that as well as the tools you're providing, and, you know, making sure that you're able to leverage, that everyone's able to leverage the tools within the clinical workflow. Multidisciplinary involvement is needed. So in the medical intensive care unit, they had daily rounds on every single patient. The checklist was and continues to be used on every single patient every single day. And so there is a workflow to use these tools, and that's why they're working. The patient care units are busy. There are many barriers to adoption. So we use the clinical champion model. That works really well. Having people on the units who are really interested in, you know, innovation, in engaging patients, and really helping and teaching their colleagues and their peers about what a difference this can make in patient care from people who know what the barriers are, right, and understand what it's like to practice in that setting. One of the issues is that, you know, we were in the ICU. Not everybody in the ICU can use devices, right, or had access to the toolkit because they were too sick. We did try to engage care partners, so we encouraged for every patient who had a care partner for them to be enrolled, but if somebody came in and they weren't able to give consent and they didn't have a proxy, they automatically couldn't participate in this study, so that was an important limitation. We learned a lot about devices. It's very complicated. We gave, for every patient in all the MICUs and all the oncology units where we did this, they all had bedside devices for a whole year. So you need a strategy around that, right? You need a strategy around how do you make sure that the data are cleaned off, right, between devices? How do you make sure from an infection control perspective that things are going well? One of our units, some of our units were oncology units. This was really a very important issue. So, you know, we had to look at all of those things as part of our project and really solve them. We wrote a whole paper about the device management, and, you know, with the projects we're doing now, we're moving to a bring your own device solution, which seems to be, I think, a more feasible solution given how much is involved with providing devices for patients. However, we do have to provide them for the patients who don't have them. We found that patients want to be engaged, but there are challenges. So some patients are not tech savvy. There are patients who don't want to use devices, and they shouldn't be forced to, right? What we found is that many patients who don't want to use devices do have family members. They have daughters, they have sons, they have spouses or partners that are interested in devices and are willing to use on their behalf. And so that was really the strategy that we used. Having more content for non-English speaking people. So Medline Plus does have some good educational content that's in Spanish, but you know, we need to work more on that. And then understanding the goals of care concept. So this is asking patients to record their goals. Not all of them know what a goal is, and not all of them believe that they're the ones that should be writing the goals. So again, you know, when we think about patient activation and patient engagement, some of the barriers are that, you know, patients are, there's a whole range of beliefs and attitudes and where they are in terms of even being able to use these types of tools. And we need more workflow, more work related to workflow integration, clinician buy-in. So you saw the difference between the results in MICU versus oncology, and a lot of that had to do with workflow and how well the tools were integrated into the workflow. So really looking at that and figuring out, how we can do that well so that the patients can benefit is an area of research. So in conclusion, Prospect improved relationships with patients and families. It reduced the likelihood that they would be harmed in the ICU. Recognition of the value of technology and its impact on workflow is really needed and critical to the success. Attention to provider readiness and workflow are key. Patient satisfaction model. So the model where we use to address patients' needs, concerns, and expectations in real time was really critical in terms of readying the environment for using these new tools. And then, technology can be used to engage patients, but we need to do more work to overcome barriers to use, looking at some of the issues I talked about around, allowing patients to use their own devices and addressing patients who don't want to use devices but maybe need other types of tools. And I think, our main lessons learned are, one of our main beliefs coming out of this is technology is really ubiquitous in every aspect of people's lives, many people's lives. And very often they come into the hospital and all of a sudden they don't have the information that they had on the outside about their health care and their treatment plans. And so, we really are obligated to provide that and to provide tools to patients so that not only do they have this information, but it's in a level of literacy that they can actually use it and really be full partners in their health care. So before I stop and take questions, I just want to acknowledge our team. The PI of the Prospect Project is David Bates from the Center for Patient Safety Research and Practice at Brigham and Women's Hospital. Thank you.
So thank you, Patty. I thought we could just open up questions and answers for a while. And also, if the previous speakers, if there are questions and answers, let's also put them on the spot. We'll run around with a mic.
When you spoke about patients' devices either provided or patients bringing devices, what are these smartphones and communicative devices, or I'm kind of fixated on medication dispensing devices, but I just wondered what you had in mind.
We provided iPads to patients at the bedside, so every patient had an iPad, and so they would log into a portal, and our toolkit was available from that portal. And we had locked it down so that they could just access that portal. That's how we handled the information security piece of it.
In terms of the, I'm fascinated with the use of your icons for the different categories that, your caregivers could use to communicate. Could you talk a little bit more about any insights you have from using those icons and the role they may play going forward with these types of systems?
Sure. Yeah, so we've done a lot, our team has done a lot of research on the use of icons. So it started out with we did our fall prevention study. So what we found is that falls are a communication problem. So nurses routinely do fall risk assessment. The degree to which they communicate the results of the assessment and the tailored plan, because it has to be tailored to prevent a fall, is really inconsistent. And so in our fall prevention research, we found that because there's so many different providers and with different literacy levels. So think about it like in an acute care hospital, right? You have physicians, doctorally prepared, and then you have nurses that are anywhere from doctorally to associate degree or prepared. And then you have nursing assistants who may have been, may just be high school graduates. Maybe their training was in another country. So we found that there were literacy issues even in the healthcare team. And we discovered this because when we were doing focus groups and we're asking people to fill out the demographic form, we saw that some of the nursing assistants had trouble So this made us see that if we're going to try to communicate the results of an assessment and the plan, we can't really use text because it's not universal. So that's what got us thinking about icons. And so we found in that particular study, the use of icons actually made a very significant, we reduced falls by 25%. Yeah, this was for hospitals. So it made a very big difference. And what we did was when the nurse completed their assessment and plan, it would automatically print out a personalized bed poster for the patient, and that went above their bed. And so anyone that walked in that room could see those icons. So you'd know at a glance, when you walk in the room, okay, if the patient says, I have to go to the bathroom, you'd know, oh, okay, well, this patient needs a walker, they need one person assist, oh, and they're confused, so I can't leave them in there, I have to wait until they see. So it provided that information. So then after that, Kamiko Schnack is here. She and a couple other, there she is back there. We expanded that. We said, okay, so we heard from the focus groups and the nurses that, yeah, this is really great for falls, but there's a lot of other information that we need to know to take care of a patient if they put on the light. So we then did a couple more years of research identifying what are those things that nurses and the care team need to know. And we expanded we worked with an illustrator and iteratively developed these icons. We've tested them with nurses, with the care team, and with patients, and have developed a whole set of them. So Kamiko's really kind of fleshing out what is the information the patient needs to participate in their safety plan. And we're also working on what are the, what's that core set of information that the care team needs right when they walk in the room. So what we've done now is based on what's documented in Epic, we are automatically displaying on screensavers on the device in the room next to the patient what that core set is. So for the patient, it's their safety plan. And for everyone else that walks in the room, this is what I need to do to help take care of this patient. So it's pretty cool. I mean, finally, and the nurses love it because finally, they're getting something back for all that documentation they do in Epic. Yeah, it's good.
Oh, thanks, Patty. That's fascinating. And that's really, I think, on the forefront of what needs to be done to engage patients in care, especially when you're looking into inpatient settings. And so a follow-up question, I just wonder what's your thinking about one of those very important aspects that you addressed here. So patient goals, right? Patient goals. That's really what should be driving in a way all the care planning activities, right? All the care coordination activities. So and they should be on the forefront of what we are doing in healthcare. That's many people are thinking this way. So what's your take? What are some of the next steps that we need to take in order to get this straight, to get the patient goals right? And some patients would not want to define goals right, and some patients would like to define goals. So how do we deal with all of this?
Okay, so I'm going to solve that problem, right? It's big. But I have some ideas. I think that, number one, I think we need to more routinely share information with patients, right? So portals are becoming much more common. And so we don't routinely share goals with patients, and we should, but we also have to have a conversation with them because, again, it's not something that comes naturally to patients. They have to know what this means and, what their role is. Because a lot of times we found that they thought, well, isn't that your role to be telling us what the goals is? And really having that conversation with them around, we want to make sure that the care you're getting here is really reflective of what's important to you. And, having a conversation. I think in end-of-life care, there's been a lot more work on this, but I think we need to do that not just in end-of-life care, but also for any person so that they can be more responsible. I don't think the healthcare system should be the owner of the patient's plan of care, right? If we're going to have longitudinal plans, then the patient needs to own them. And the only way to do that is to have them really, be so activated that they, think it's a priority to maintain those.
Hi, I have a question for Dr. Kelly, actually. Hi, my name is Tim Radersdorf. I'm the Chief Innovation Officer at Ohio State University College of Nursing. Wanted to thank you for sharing your journey with us. I noticed on one of your slides that you said patent pending for your app. and we've been doing a lot of app development, and I've always gotten kind of conflicting legal advice as to whether you choose a patent, copyright, trademark for your product. So I was wondering if you could share the decision that you made of why you went for a patent.
Sure, that's a very good question. As I mentioned, I had no prior experience in entrepreneurship or intellectual property. I was advised to first speak to my university as to who owns the technology and the idea. And so that was the first thing I did, was to go to the university and fill out the paperwork, and it was reviewed. And I had a conversation with their office. What's the difference between patent, trademarks, copyrights? And you will hear different opinions. I've heard that as well. I felt strongly that I wanted to pursue a patent for the idea, for the technology. And the school was willing to work with me if I wanted to go that route, but it was granted to be something that was I own, not the university. So from there, privately, I sought out a patent attorney who worked with me to do the steps that you would need to do, which is go through the database. Is there anything else that's like this? And then go through the process of writing it. And it takes a long time. That process took about a year. And then it's been sitting in review, pending, as you saw, for about 3 years now. So it's a long journey. Yeah, it takes a long time for it to be reviewed, and then it gets reviewed, and we'll see what feedback comes back. It's not a guarantee, but I felt that this is something in the space that I'm in that would allow me potentially some more value down the road to see what the outcome would be. So if anyone's interested, there's multiple different ways to explore that. People are more than willing usually to have a conversation with you about that. And then you need to make the decision for yourself what you think is right.
Is the patent on your algorithm, or is the patent a software patent?
It's a utility patent and a bidirectional interface for the software. So that is the route that I chose to go. And then I'll cover trademarks. So we've trademarked Know My Patient and the logo for the company. And again, that's another usually conversation about, should I trademark this? It's a little bit of a quicker turnaround time, but they do want to see if it's in use to approve it. And then there's steps that can take place. But again, people are usually more than willing to talk to you about those things. So if anyone has questions about that further, I'm happy to sort of give you my experience and or point you in the direction of someone you could talk to. Hope that helped. Does that answer? Great, thank you.
Patty, I wondered if, did you measure at all the clinicians' satisfaction with using it, and what was their feedback? You know,
All right, so you know what the barrier was to that?
Yeah.
We had to come off because Epic was going up. So we went down the day before Epic went up, and so we were afraid to measure, we measured pre-satisfaction.
It would be confounded.
Yeah, exactly. Well, people were not happy after Epic went up at first.
Yeah.
Nothing to do with Epic, I'm sure.
Right,
it's just that new system. And yeah, so we actually didn't conduct post-satisfaction because we knew the environment was.
Yeah. And how did they know they had a message from the patient or caregiver? Did they get
They would get
pinged
a little,
some way?
Yeah, they would get a little message.
And was it annoying to them? Did they
could
get
set
inundated
their-
with messages, or were they pretty rare?
They could set how frequently they wanted to get them. So because we had managed expectations with the patient, that you would hear either through this or by the beds, someone coming to the bedside within 24 hours, they could set their notifications so that they just found out once a day, like who had messaged them.
Okay.
I have a question. My question is, I think the microblog is absolutely wonderful. Is that part of the permanent medical record, and is it printed out and sent to insurers as part, or governmental agencies as part of the medical record?
No.
Is it discoverable?
No, it's not. I mean, we were considering it like text pages, You know, so with the text, when somebody sends a text message, it's not something that becomes part of the medical record, or if you send an email. So what we're trying to do is, you know, get rid of all the different siloed forms of communication and have one method that the whole team could be privy to. And so these other forms of communication that we were not using were not part of the medical record. I mean, that's a question, though, that's asked frequently. And, you know, if it had to be discovered, could it? Yeah, I mean, there's always records of these things, but it wasn't something that we considered part of the medical record.
Thank you.
I just have a quick question, if I'm straight ahead.
Oh.
I didn't know if you covered this in the beginning. How did you handle different languages?
So we had the ability to enroll English or Spanish speaking people, but really most of our content was English. Medline Plus does have a lot of Spanish content, but we really didn't, you know, it was more like a pilot from that perspective. We hadn't expanded it to multi-languages. The thing is, though, like at the Brigham, a lot of the patients who don't speak English, they have a family member or someone who does that they were willing to enroll. So we tried to handle it that way. If there's someone that was not English speaking, we tried to, you know, enroll somebody that, you know, the patient was okay with them enrolling to help them. We do think that every patient should have a care partner that, you know, English speaking or not, you know, patients, when they're in the hospital, they're there because they're sick, and sometimes they're not able to communicate or, you know, advocate for themselves. And so for that reason, every patient should really have someone who can help them, you know, so the patient can use the tools if they're able, if they want to, but we really think it's helpful for every patient, you know, to have someone who's looking out for them and paying attention. Okay, thank you.